లేదంటే మళ్ళా ఇంకోసారి లింక్ ఓపెన్ చేసి రీస్టార్ట్ చేయమనండి.
లేదంటే స్లైడ్స్ షేర్ చేయమనండి, ఇక్కడ నుంచి స్క్రీన్ చేద్దాం.
Shinju, leave the page and again restart. Okay, start the class, please. Are you ready?
Sir, am I audible, sir?
Yeah. Shall we start?
Yes, sir. I'm starting without the video, sir.
Yeah, sure. No problem. Good morning, all of you. Sorry for the late.
Okay, sir.
I request Dr. Rani Madam to introduce the speaker and the moderator.
Yes.
Hello, good morning. Today we are going to have a talk on imaging CT brain by Dr. Sinju. She's a post DNB IDCCM student at Care Hospital, Visakhapatnam. And our moderator going to be interventional radiologist, Dr. Rajesh Pusarla. He is MD, DNB, DM, interventional radiologist. So, Dr. Rajesh, welcome to the class this morning. Sinju, start. Thank you.
Good morning, everyone. Today I'll be talking about approach to CT scan of a brain. So here is my outline. I'll be proceeding with general anatomy first, followed by mass effect. What are we supposed to look out for? Like how to rule out bleed and stroke, basically, and what else to look for, like soft tissue fractures. Basically, a CT scan would be taken along these axial sections, uh, starting from centrum semiovale, lateral ventricles, third ventricle, midbrain, suprasellar system, and sella turcica, and pontomedullary junction. So these are how do we obtain the CT axial sections. So starting from anatomy here, we starting from anatomy, here is the axial section which is taken along the pontomedullary junction. So what we see over here in the first slide is the orbit, the frontal bone. Here is our sphenoid sinus, the two temporal lobes, and the external auditory meatus in the mastoid hair cells, followed by the cerebral hemispheres and the pontomedullary junction. Now, when we look at closely at this kind of structure, it somewhat resembles like that of a Darth Vader character from Star Wars. So now next, when we are looking at this section is taken through Sella turcica. This is where the pituitary stalk is, and this is the frontal lobe. Here we have the orbital part of the frontal lobe, frontal bone, and this is this is a basilar artery which is seen over here in front of the pons. And here we have external auditory meatus, the two temporal lobes, and the cerebellar hemispheres. This ocean is taken along the suprasellar cistern. This is a suprasellar cistern. This cistern is important in the anatomy of brain. Why? Because here is where the circular villus would have various branches. And this is the portion of fourth ventricle. And this portion, which is somewhat similar to the Mickey Mouse head, is what represents the cerebral peduncle, which projects out from this midbrain here. Here are the temporal lobes, frontal lobe, and what we have here is our occipital lobe, and here we have a cerebellar vermis. Now coming to this section, when you look at this smiley-like portion, the smile-like portion is what is represented by what you get is a quadrigeminal plate cistern, and here you find a third ventricle, the anterior horns of the lateral ventricles. So the dura which is projecting from here is pars cerebri, and this is our frontal lobe, and this would be our cerebellar hemisphere. Now coming to this section, here what we get is both the horns and anterior horns of the lateral ventricle, the third ventricle, and again quadrigeminal plate system, and the frontal lobe here, and posteriorly we have occipital lobe. So here what we get is what you're looking for is the again the ventricles, but the physiologically hyperdense lesions which you are finding in here is basically choroid plexus, and this is pineal gland. These are the choroid plexus, which you can find it in the posterior horns of the lateral ventricles. And here what you get is a straight sinus, and what else to look for is the gray matter, which is the important findings over here, gray matter and the white matter. The gray matter here is our caudate nucleus, which is adjacent to the anterior horn of the lateral ventricles. Here what we have is a caudate, this one is our thalamus, and the slightly dark or hyperdense lesion what you're getting over here is nothing but internal capsule, and the lenticular form of structure which you're getting over here is nothing but the globus pallidus medially, and laterally we have putamen. These are the posterior horns of the lateral ventricle. And this section, which is taken at the level of the lateral ventricles well above, here it is nothing between banana-like structure which are opposed to each other are the lateral ventricles. The body of the lateral ventricles basically, here we have the frontal lobe, the dura falx cerebri, the dura invagination into the cerebral hemisphere, and what you're getting over here is the superior sagittal sinus. And these are the occipital lobe and the frontal lobe. And laterally, what you're getting is a parietal lobe. And this is well above, it's at the level of the central semivalley. What you're getting, or what you're supposed to look for is the invaginations, or basically all these indentations or grooving in the cerebral cortex, which is nothing but the various sulci, and the projections which you get over the cerebral cortex is nothing but the gyrus. Here is our falx cerebri, and this is our superior sagittal sinus. This was a video in which I was going through the anatomy, but it's not getting played, so I'll go ahead. Again, a video representing the CT angle. So what else to look for is the anatomy of the vessels. This is our circular villus, which is made from the internal carotid artery and the vertebral basilar artery, which sits at the level of the pituitary stalk. And internal carotid artery, anteriorly it gives off anterior cerebral artery and middle cerebral artery, and both the anterior cerebral artery from either side would communicate through the anterior communicating artery, and the communication between internal carotid artery and the posterior cerebral artery would be our posterior communicating artery. So here are some of the physiological hyperdense lesions. Other than, as previously pointed out, the choroid plexus and the pineal gland. Here are some other changes, globus pallidus, which you might find over here. Dentate nucleus is usually not physiological. It can be pathological as well, but I just included it in this slide. Arterial supply of a brain. So here you find the lateral surface of the brain, which is supplied by the middle cerebral artery, except the portions of the inferior temporal lobe and the superior portion of the superior portions of the parietal lobe, which is again supplied by the anterior cerebral artery, which also supplies the medial portion of the frontal lobe, and the posterior cerebral artery, which gives you the supply to the occipital lobe and the inferior portions of the temporal lobe. So here is the cut section, a diagrammatic color description of what you're supposed to look at the level of this cut section of brain. So sometimes the internal carotid artery and the jugular venous bulb is also to be pointed out and to be looked out for. So here, the structures which you're supposed to look for is the various vessels and the pituitary gland over here and the sella thoracica. Next. Okay. So next is the gray matter structure. What you're finding over here, basically the gray matter structure which you're finding over here is like the caudate nucleus, the thalamus, the globus, the lenticular-form structure, which is the globus pallidus and the putamen. And here we have the internal capsule, the anterior limb and the posterior limb and the journal. And outside we have the external capsule. Here what you find is the interhemispheric fissure. And this is our cerebellar vermis. So this is a basic outline of our the ventricles. So we have an anterior horn of the lateral ventricle. It's the inferior horn, and this inferior horn goes into the temporal lobe, and this is the posterior horn, which is seen.
Speak loudly.
Yes, sir. So this is nothing but the diagrammatic depiction of the ventricles, how it is oriented. So we have a lateral ventricle, its anterior horn, which would be seen projecting into the frontal lobe, and here it's inferior horn, which is seen at the level of the temporal lobe, and the posterior horn of the lateral ventricle. And this connection, which you can see, the lateral ventricle communicates with the third ventricle via the foramen of Monro, and the third ventricle communicates with the fourth ventricle via the cerebral aqueduct, and the fourth ventricle would continue as the central canal. So the choroid plexus, which lies within the ventricles, is what makes up the CSF, and that is what continues into this as its content. This is just an outline of what are the layers which you're supposed to look for. So starting from dura matter, arachnoid matter, and pia matter. So coming to the basic, the household units, which is used by the radiologist. So it's nothing but a semi-quantitative measurement of radiological attenuation, which is used by the radiologist in order to find out the density of any tissue. So basically, a figure of -1000 is allocated for air, and a figure of +1000 is allocated for bone or metals. And the soft tissue is given a figure of a +50 Hounsfield units, and 0 is taken as the midline over here. Fat has considerably lower density compared to water, which is a figure of -100 Hounsfield units. So in order to look for any structure that is appropriate windowing is required. So when you're looking at any image, so appropriate windowing would be done at this level. So you by default, when you're looking at a CT brain structure, what you get is a brain window, which has a width level of 70, width of 70 and a level of 30. So when you're looking for any hyperdense lesions, basically a bleed or something, which would have a figure of +80 Hounsfield units, but this +80 units, and if you're keeping it still at the level of 30, this would project itself as white in density, which would be considerably white, and one cannot make out the skull bone, the differentiation between the skull bone and this whitish colored bleed, which is when it is lying in close proximity to the skull bone structure. So that is the reason why we have to look. And similarly, in case of stroke window as well, when you're looking at a stroke window, the white matter and gray matter, it would almost, this white matter has a density around plus 15 household units, and the gray matter around plus 40 household units. So if you do not adjust the width and the level at 30, what you might get is something which is very homogeneous in structure. That's the reason even for soft tissue and bone window also, we require adjustment of the width and level. So here, so I'm moving ahead with the stroke. So what we have two types of stroke, ischemic and hemorrhagic. So ischemic stroke can give two types again, thrombotic and embolic. So other than this, we have hemodynamic stroke as well. So hemodynamic stroke is something which you find in hemodynamically compromised patients when the cerebral perfusion pressure that is reduced to considerably lower levels, to critically low levels, which in turn would cause decreased supply to vulnerable soft tissue, which is lying in the watershed areas, which is drained, which is supplied by either arteriocerebral artery or the MCA or the PCA. So in such cases, you would even find hemodynamic stroke. So other than that, embolic stroke, you would find it can be of two types again, cardiac and arterial. So cardiac ones, you would find it in association with the atrial fibrillation and in patients with foramen ovale. And likewise in arterial ones, they have of two types, primary and secondary hypercoagulopathy. So again, this hemorrhagic type can be again divided into intracranial and subarachnoid types. So intracranial type is the cause can be even hypertension or congophilic angiopathy, and subarachnoid types we have either because of barrier aneurysm, arteriovenous malformation, or vessel malformation like dissection, etc. So the stroke, when you get a stroke, in order to differentiate whether it is a large vessel stroke or a medium vessel stroke or a small vessel stroke, one can also make out using the kind of features or the presenting features of the clinical manifestations what you would get. So a monocular blindness or any pure AC or MCA infarct would be found in case if the IC territory is involved. Likewise, in vertebrobasilar territory infarct, again, you would go for looking at this 4Ds, that is a dizziness, dysphagia, diplopia, and dysarthria, and like this nausea and vomiting. And any medium vessel stroke, ACA, MCA, or PCA territory infarct. If ACA territory infarct is involved, both motor and sensory deficit would be found, but more at the level of the lower extremity when compared to face or upper extremity level. Whereas in case of MC infarct, this again, it would be more at the level of upper extremity and face when compared to the lower extremity level. So, and if the dominant hemisphere is involved, you would find aphasia, and if non-dominant hemisphere is involved, you'd find hemi-neglect. So PCA territory infarct would again present with homonymous hemianopia or visual hallucinations and sensory loss or motor deficit. Small vessel vascular infarct would again be either pure motor or pure sensory deficit. Now moving on, any kind of bleed which is seen on CT scan would have plus 80 household units on a scale like this, whereas white matter would correspond to plus 25 household units and gray matter would correspond to plus 40 household units, whereas the CSF would have a density of plus 15, which is closer to water. So here what you're looking at is an EDH. The first figure is
Sindhu.
Yes, sir.
Yeah. So till the normal anatomy is over, we will make, if necessary, we'll make it 2 classes also. So that it is very important class for CT scans. So I request Dr. Rajesh to interfere about the normal anatomy of the CT brain to elaborate, and we want that some more explanation from him. Sir, then you can start again pathology, Sindhu. Is that okay for others?
So you're saying, sir, I should repeat whatever I said?
No, not repeat. I request moderator Dr. Rakesh to interfere at this level of anatomy. Then we can go to pathology. When his input is over.
Oh, okay.
Okay, sir. We'll start with
Yeah.
So,
Sir, am I audible?
Yes, sir.
Okay. So now, before I just start with the Hounsfield unit, sir, which he has mentioned, that is because it is important when interpreting a CT scan. What is relevant? How do we keep these Hounsfield units in that? So initially, as is, there are HU values ranging from -1000 to +1000. This is what Grayfield Hounsfield has mentioned us. But irony is that we have around only 34 to 35 shades of gray. From the most brightest to the most darkest, it can be represented only in 35 values. But range from -1000 to +1000. And even metallic objects, we have seen up to +1500, +2000 HU also. So we have only a
సార్
32
కొంచెం
shades.
loud గా మాట్లాడండి సార్.
Okay,
Mic
sir.
కొంచెం పెట్టు.
Okay. So we have only a few gray color scales to represent the entire set of the HU values from -1000 to +1000. So it is not possible to assign a different color for each set of HU value for a single HU value. So what we do is based on which structure we are looking at, what are the pathology we are looking at, we try to adjust the window of the Hounsfield units in a level so that whatever pathology we want to look for bleed, our level is at a level, our HU level is set so that we are able to look at the field. So there are two levels, window level and window width. That is what we call. Window level is what exactly you want to look at. You want to look at the brain parenchyma, you want to look at the bleed, you want to look at the soft tissue, you want to look at the bone. So when you are looking at the bone, the window level will be at a higher because you want to look at the higher HU field units. And when you are looking for fat, your window level will be lower. And when you are looking at the brain, the level is different. So, and what is width? With this, all your Hounsfield units, the gray colors of the gray are adjusted within this width. So then the most brightest to the most darkest are usually adjusted between 30 plus or minus 70. So 30 is the level. So 70 on either side is your level. So from 30 to -70, so you get up to -40, 30 to +70 to +100. So -40 to +100 is your normal CT scan viewing width. So within this width of a width from -40 to +100, all your colors of gray is adjusted within those 140 width. So if you expand the width, the colors will be adjusted accordingly. So that is what is windowing. When you keep a narrow window, so like this, like a stroke window, 30 to 30, your width reduces. So only from 0 to 60, within a, you're adjusting your colors within 0 to 60. So you are able to assign for every 2 Hounsfield units, you have a different set of a gray color. So the better appreciation will be present. So because we are confining the window width and the window level. I hope now itself, if anybody want to ask regarding the any questions regarding window width and window level, I'll be happy to answer. If not, then I'll start with the anatomy. So anatomy sections as been represented. Here the right side is actually a T1 weighted MR image of the brain, and the left side you have the corresponding CT images. So what we call is from the orbits initially at the level of the orbits, or you plan it image, you plan it back to the section of the corpus. The way the corpus callosum is so forms the anterior posterior dimensions of the brain. So here it is a bit more tilted downwards. Your scanning plane should be parallel to that of the orbits when you do a CT, or to that of the corpus callosum when you do an MR. As we start planning up, you have to see the symmetricity, whether it's symmetric or not. So here we are right side or not symmetric. Left cerebellar hemisphere either your plane is not symmetric or there is an atrophy of the right left side. So coming from the basal cuts are known as the basic temporal, or the basal frontal lobes are known as the basic frontal region. So it is difficult to differentiate on the different sulci like the superior, middle, and the inferior temporal gyrus on the CT, but on MR you'll be able to differentiate. What you want to appreciate here in the lowermost cut is whether are you able to see any tonsillar protrusions, or initially you have the and this part of the cerebellar hemisphere is made by the pica territory, the cerebellar artery. So any infarcts in this level, you think of the pica territory infarct, and then you have the lower cuts of the medulla oblongata, and the fourth ventricle usually ends at this level. It is only the central canal which starts, or the fourth ventricular outlet which comes here, which is a foramen of Magendie and Wishart, which is going again. So then and then the base, as we said, the basic temporal cuts you are having, and then the orbits, and sometimes you'll be able to represent the optic nerve center. And this is the external auditory meatus, and these are the mastoid air cells. And the systems which you are seeing around the medulla are known as the perimedullary systems. It is important to identify the systems. If you are not able to identify the CSF space around the medulla here, then you can think of raised ICPs or any conditions where there is herniations, which is compromising the CSF spaces, or any cerebellar edemas, which is reducing the CSF spaces. So appreciation of the CSF around the brainstem or the medulla oblongata is very important. So gradually, now the next cut. Here we are able to see at the belly of the pons. This is the belly of the pons. We are seeing that the cut is passing through the belly of the pons, and now from the pons we have moved slightly higher up into the lower sections of the cerebellum, and we have just touched the basal region of the frontal lobe, which is the basic frontal, as you mentioned. So now whatever you are usually seeing here is known as the basic frontal areas. And again, you have coming from posterior to anterior, you have the cerebellar hemispheres. Then midline, the vermis is, will be starting here. And now you'll be able to see the inferior most cuts of the fourth ventricle. So here also, this is the fourth ventricle, and you have the inferior projection of the fourth ventricle, which is represented here. And now you see the pons. So pons is expanded anteriorly. So when compared to the midbrain and the medulla, you see the pons expanded anteriorly, and you see the basilar artery in front of the pons, or this is the prepontine system. What is in front here is known as the prepontine system. You should appreciate the basilar artery. And now you see the bulk of the temporal lobes in this cut. The medial temporal lobes, which called, and the uncus is present. Any conditions of uncal herniations and all, we check the CSF spaces at this point to see the uncus. Superior. So here you also actually the cut is passing through the pituitary. So if you with the presence of the solid bone of the sphenoid, you will not be able to appreciate the pituitary. Only once we come into the bone window, we'll be able to appreciate the pituitary groove, the dorsum cella, and the clinoid process center. So then the bone, so you have to see that in a bone window, or you have to reduce, you have to slightly do the windowing to understand how the pituitary groove or the normal pituitary is present. So subcutaneous and the scalp tissues are present across all levels. You have the crista gallis starting here, which is the attachment of the tensorium at a higher level. So now we are still again we have both the posterior hemisphere and the anterior hemisphere. Here we are slightly we are coming into the superior aspects of the temporal lobes, and now again we are entering. So this is actually the MR image is not corresponding to the CT. Here we are at the slightly higher level where we are corresponding to the section is actually passing through the midbrain.
సార్ కొంచెం పెద్దగా మాట్లాడండి సార్, ఇది మైక్ దగ్గర పెట్టండి సార్, లో వాల్యూమ్ వస్తుంది.
Okay, sir. Okay. So this section is again passing through the cerebellar hemisphere, and it is passing through the pons and the frontal lobes. So, but here this is the section of the again midbrain and pontine junction, which are able to see here. And now we are able to see the entire fourth ventricle, which is pyramidal in shape. This is a suprasellar system. The one which is anterior to in the prepontine system or the perimedullary systems. This is the again the basilar artery. Sorry, this is the basilar artery. And you see the commencement of the Sylvian fissures. And this is the entire frontal lobe. Previously, we were seeing the basifrontal lobe. Now we have the frontal lobe cortex here. And this is at the level of the superior temporal gyrus. And this is at the level of the inferior frontal gyrus. And medially, you'll be able to see the cingulate gyrus here coming to this section. And here you are able to see the superior cerebellar hemispheres, which is again supplied by the territory of the scar. The superior cerebellar artery supplies the superior portion of the cerebellar hemispheres. And either side of the vermis, you see the gray nuclei. Usually you see the dentate globiform, a combination of 4 gray nuclei which are present on either side of the vermis here. And then one section higher, now we have come up to the third ventricle and the lateral ventricle. Previously, you were only seeing the fourth, and this is the superior most sections of the cerebellar hemisphere. And here you are starting the third ventricle and the frontal horns of the lateral ventricles. And section at a section higher, you'll see the occipital horns and the temporal horns. Here you're able to see the posterior invagination of the Sylvian fissures. And then you have the ambient systems in the quadrigeminal plate system, and the quadrigeminal plate systems continue laterally as the ambient systems. So, and another section higher, you start the beginning of the basal ganglia here. You're able to see the caudate nucleus lining the frontal horn, and you see the lentiform nucleus. Between the caudate and the lentiform, you see a gray colored structure. So white matter, these are gray matters, you see white matter. This white matter is again divided into anterior limb of internal capsule, genu, and a posterior limb of internal capsule. And medially lining the third ventricle and the foramen of Monro, you have the thalamus. And thalamus is a combination of 6 gray nuclei again. And thalamus, both the thalamus are separated by the third ventricle in the midline. And here you have the quadrigeminal system, the cerebellar vermis, and the superiormost cuts of the cerebellar hemispheres. And lateral to the basal ganglia, the lentiform nucleus, you see the external capsule, and then the extreme capsule, difficult to appreciate on the CT, and then you see the insular cortex. Insular cortex is the one which is lined by the Sylvian fissures. So the gray matter which is lining the Sylvian fissures is known as the insular cortex. And here at this, you see the occipital lobes posteriorly. If you have a very degenerated brain, you'll be able to appreciate the sulci which are separating the occipital and the temporal lobes and the frontal lobe. And then a section higher, again, now we are coming into the posterior horns start beginning, and you have the internal cerebral veins in the midline. And this is the corpus callosum, the genu of the corpus callosum. Here you see the section passing through the corpus callosum. The frontal lobes, again, you are able to see the basal ganglia, caudate, thalami, and then posteriorly you have the occipital lobe, and the parietal lobe is not yet starting. This predominantly is the frontal lobe sections here, and part of the temporal lobe followed by the occipital lobes. Then this is actually the higher sections of the lateral ventricles. Here you have the frontal lobes and the parietal lobes. The occipital lobe usually ends here. Medially, a portion of the occipital lobe may be present, but predominantly it's the frontal and the parietal lobe will be beginning here. You have the corpus callosum. The posterior section of the corpus callosum is what we are seeing. The midline, what separates the both cerebral hemispheres are the falx cerebri, and the tent-like structure, the triangular structure which you see anteriorly and posteriorly is the superior sagittal sinus. So again, the falx cerebri, the interhemispheric fissure, and now we are into the higher cuts. So you see the high frontal and the high parietal cuts here, which is separated by the precentral gyrus or the central sulcus, which is usually the deepest sulcus, which you see in the brain parenchyma, the central sulcus, which will be separating the frontal and the higher. And here you do not see any ventricular structure. The ventricles are finished by this stage, and the medial territory is the cingulate gyrus. Cingulate gyrus is actually completed. This is all supplied by the anterior cerebral artery territory, and the lateral which is supplied by the middle cerebral artery territory. Okay, so another cut, and the white matter, all this we know, the white matter is known as the centrum semi-ovale. At the higher levels, anything higher than the lateral ventricles, we call it the centrum semi-ovale, and anything at the level of the body of the lateral ventricles or beneath is known as the corona radiata. The corona radiata, so basically white matter is nothing but they are communications between gray matter structures. They end up as a projection communicating between two gray matter structures. So, and they leave as corticospinal tracts into the brainstem, and they go and enter into the spinal cord. Sir, anything specifically do you want me to talk about, sir?
Okay, sir. Thank you, sir. Thank you for explained elaborately. And now I request Sinju to continue.
సరిగా వాయిస్ వినపడలేదు.
సార్
సరిగా వాయిస్ వినపడలేదు సార్.
అవును సార్, కొంచెం లోలో ఉంది, అది పర్లేదు, తర్వాత అడ్జస్ట్ అయింది కదా.
Sir, can I start now?
Yes, Sinju. Yeah.
రాజేష్ సార్, రాజేష్ సార్,
Sir, tell me, sir.
వినపడుతుందా సార్?
వినిపిస్తుంది సార్, చెప్పండి సార్, చెప్పండి.
ఇప్పుడు వైట్ సిటీ స్కాన్ లో ఓన్లీ వైట్ మ్యాటర్ డిమైలినేషన్ వస్తుందా సార్?
సిటీ స్కాన్ లో డిమైలినేషన్ అని అసలు అనలేము సార్. అది
ఎన్ఎండి ఏదో ఉంటుంది, ఎన్ఎంఈడియా
సార్,
అదే న్యూరో డిమైలినేటింగ్ ఏదో ఉంటుంది కదా సార్ డిసీజ్.
అది కొన్ని చాలా సార్లు డిమైలినేషన్ అసలు సిటీ స్కాన్ లో కనిపించదు సార్. ఎప్పుడైనా మనకి వైట్ మ్యాటర్ హైపోడెన్స్ కనిపిస్తే సిటీలో మనం అది డిమైలినేషన్ అని చెప్పలేము సార్. అది వేరియస్ అదర్ పెథాలజీస్ కూడా ఉండొచ్చు. యూజువలీ మోస్ట్ ఆఫ్ ద టైమ్స్ మల్టిపుల్ స్క్లెరోసిస్ కానీ ఏడమ్ కానీ ఇవన్నీ అసలు వైట్ మ్యాటర్ డిఫరెన్స్ ఏమి మనం సిటీ స్కాన్ లో అప్రిషియేట్ చేయలేము సార్. విల్ నాట్ బి ఏబుల్ టు.
ఏం లేదు సార్, ఒక 24 years బాయ్ ఎంటైర్ వైట్ మ్యాటర్ డిమైలినేటింగ్ వచ్చి లాస్ట్ 20 days లో బాగా డిటరేట్ అయిపోయి వస్తే అది ఎన్ఎండి అని డయాగ్నోస్ చేశారు సత్యరావు గారు.
ఓకే సార్,
అది సిటీ స్కాన్ పెట్టి ఎక్స్ప్లెయిన్ చేశారు. కార్పస్ కెలోసిస్ తో సహా మొత్తం ఎంటైర్ వైట్ మ్యాటర్ అంతా డిమైలినేట్ వైట్ వచ్చింది.
కంప్లీట్ గా బర్న్ అవుట్ అయిపోయినా అంటే అడ్వాన్స్ స్టేజెస్ లో ఎప్పుడైతే మొత్తం వైట్
అలా అయిపోయింది సార్ ఓన్లీ సిటీ స్కాన్ లోనే.
ఇప్పుడు చాలా హైపోడెన్స్ గా చాలా డార్క్ గా ఉంటుంది సార్. సో అంటే
తెల్లగా ఉంది.
సో బేసిక్లీ ఏమవుతుందంటే సార్, మొత్తం మైలిన్ అంతా పోయి జస్ట్ ఫ్లూయిడ్ అక్యూములేషన్ ఉంటుంది. ఆ ఫ్లూయిడ్ అక్యూములేషన్ వల్ల ఏంటంటే మనకి ఎంఆర్ఐలో T2 లో చూసినా బ్రైట్ గా కనిపిస్తుంది, సిటీలో చూసినా కూడా ఇట్ విల్ స్టార్ట్ గోయింగ్, అంటే ఫ్లూయిడ్ వైపు వెళ్తున్నట్టు, అంటే ఆన్స్ఫిల్ యూనిట్స్ తగ్గిపోతూ ఉంటాయి. మనం డెన్సిటీ ఏమో ఫ్లూయిడ్ డెన్సిటీ వైపు వెళ్తున్నట్టు ఉంటుంది. ఇంకా ఆ స్టేజ్ కి సిటీలో మనం డిమైలినేషన్ అప్రిషియేట్ చేసే స్టేజ్కి వచ్చిందంటే అది కంప్లీట్లీ బర్న్ట్ అవుట్ అని అర్థం సార్. ఇంకా
రికవరీ ఛాన్స్ ఉంటుందా సార్ వాళ్ళకి? అంటే మామూలుగా స్టీరాయిడ్ ఇస్తే, అంటే గ్రే మ్యాటర్ వైట్ మ్యాటర్ పూర్తిగా పోయినప్పుడు వైట్ మ్యాటర్ అలా అయితే డిమైలినేట్ అవుతాయి.
యూజువల్ గా వైట్ మ్యాటర్ డిమైలినేషన్ ఏంటంటే గ్రే మ్యాటర్ వైట్ మ్యాటర్ డిఫరెన్సియేషన్ ఇంకా ఎక్కువ బాగా ప్రొనౌన్స్ గా కనిపిస్తుంది సార్. ఎందుకంటే వైట్ మ్యాటర్ ఇంకా డెన్సిటీ తగ్గిపోతుంది కాబట్టి ద గ్రే వైట్ మ్యాటర్ డిఫరెన్సియేషన్ బికమ్స్ మోర్ ప్రొనౌన్స్డ్ ఇన్ సచ్ స్టేజెస్. మనకి ఆ డిఫరెన్సియేషన్ ఇంకా క్లియర్ కట్ గా ఉంటుంది.
ఓకే సార్, థ్యాంక్ యూ సార్.
Thank you, sir. Sir, just tell us about the vascular anatomy also. So, as Sinju has pointed out, so circle of Willis is the most important thing. So, circle of Willis basically contains both the basilar artery, both the bifurcations into the PCA, PCOM, ACA, and the anterior communicating artery. We have to understand that the middle cerebral arteries and the vertebral arteries, they are not part of the the middle cerebral arteries, they are not part of the circle of Willis, because embryologically the middle cerebral arteries are nothing but branch of the anterior cerebral arteries. So in the infant stage, the anterior cerebral arteries are the dominant branches which supply the middle cerebral artery. Only later on the middle cerebral artery fades off. So embryologically, and the circle of Willis doesn't include the middle cerebral artery. So this is only to maintain that to understand that there are collateral pathways in the brain. The idea is none of the patients, 90% of the patients do not have a complete circle of Willis. You have to understand that they may have an absent anterior communicating, they may have an absent posterior communicating, or one side of the P1 may be hypoplastic. 80 to 90% of the patients do not have a complete circle of Willis. Only in 10 to 20% of the patients we see a complete circle of Willis. And the circle of Willis only means suppose there is no P1 PCA means
సార్ కొంచెం మైక్ దగ్గర పెట్టండి సార్.
సార్ కొంచెం వాయిస్ గట్టిగా చెప్పరా ప్లీజ్.
సార్ యాక్చువల్గా గట్టిగా అరుస్తున్నాను సార్ నేను ఇక్కడ.
మైక్ దగ్గర పెట్టండి చాలు. క్లోజ్ టు యువర్ మౌత్ మైక్ అంతే. దట్స్ ఎనఫ్.
సార్ ఇప్పుడు వినిపిస్తుందా సార్?
Yes sir, yes sir.
Okay, so usually when we do not see one P1 PCA or when we do not see one posterior communicating artery arising, so we have to just check how the alternate pathways are there. So even in cases of stenosis, suppose there is a severe ICS stenosis, but if there is a good PCOM which is coming from the basilar artery, from the P1 PCA, the PCOM, and it's filling the internal carotid artery and the entire AC and MCA. In such cases, we do not need to do an ICA intervention immediately. We know that we have to see whether the perfusion is very good coming from the PCOM or not. So in cases when you do not have good PCOMs and then you see ICS stenosis, those are the cases when we intervene, when we need to intervene quickly. So the circle of Willis not only provides collateral pathways in acute stroke, it also acts as a guidance, a guide tool when you are planning any intervention. So when you want to do an ICA ligation or you want to do suppose there is a large basilar artery aneurysm, you want to occlude the basilar artery, you can occlude the basilar artery provided it has good posterior communicating arteries. If there are good posterior communicating arteries, and even then you understand, even if you occlude the basilar artery, you will understand that the posterior communicating arteries will fill the PCA and retrogradely even the basilar and its perforators. So here there is a large aneurysm here at the level of the basilar formation. I want to occlude the entire artery here along with the aneurysm. I can occlude it safely when I know that the PCOMs are very good. So the circle of Willis also acts to understand when we are planning any intervention also. So it is important to know the vascular territories when you are dealing with the anatomy, whether it's an ACA infarct, MCA infarct, because sometimes you'll be seeing both multiple areas of vascular territories being involved. In such situation, you must understand whether it's an embolic phenomena or there are cases when you see a large ICA infarct along with a PCA infarct also. In such situation, it is understood that the ICA is only supplying the PCA via the PCOM. If you are seeing a large MCA and a PCA infarct, we must always check that the PCOM, the ICA is infarcted and the PCOM is also gone, and there is no supply from the P1 PCA. In such situations, you'll see multiple territories being infarcted. So suppose the PCOM is only filling the ICA and its branches, and you have occlusion of the basilar and the P1 PCA. So automatically you see, though it is a posterior circulation stroke, because it is filling the anterior circulation also, you'll be seeing infarction in the anterior circulation territory. So understanding the vessels in the particular case is important to know how the vascular infarction has happened. Rather than thinking of two different vascular territories, usually it will be a single vascular territory which is also reinforcing the other vascular territory. So in such situations, even a single vessel being infarcted also leads to multiple vascular territories being infarcted. So this may sound complex, but I just want to make the main point which I want to highlight is sometimes there might be a single vessel which supplies multiple vascular territories also, because that is because of the circle of Willis. That is what I want to highlight.
Thank you, sir. Shinju.
Yes, sir.
We have very less time. If possible, we can continue in the next class. Is it okay for you?
Sure.
Yeah, then we will, madam, come on, sir. If you have any doubts regarding the anatomy, please ask. And the pathology can be discussed in the next class. Okay? Hello?
Yes, sir.
Yeah, pathology will be in the next class. And any doubts regarding the anatomy, you can ask the presenter and the moderator. Hello?
Hello.
Hello?
Hello, sir. Yes, tell me, sir.
No, others are not responding.
Sir, I'm trying to play.
Yeah. So, Shinzu, in which condition the CT scan image is preferable than MRI?
Excuse me, sir. Hello.
Yeah, talk loudly and keep your mic near your mouth.
Hello, sir. Can you see that video?
Yes. See.
Yeah, we could see.
Yes, sir. So, this is what I wanted to explain through this video, actually. Let me- Achha, sir. Tell me, sir, question. Any conditions where we prefer CPR for in initial stages of stroke, if it is any lesion which you're looking for is not visible on CT, then we would go for MRI to and any demyelinating pathologies which we cannot make out on CT. Any causes of seizures like meningitis and all we cannot make out on CT very well. And in conditions like again like
Enter sound. Hello?
hello, sir.
You're not able to hear, Shinzu.
Hello.
Yes,
Hello.
please talk loudly.
Hello, sir.
Keep your mic near your mouth and talk loudly.
Yes, sir. Sir,
Yes.
the first thing would be in case of trauma, we'd go for MRI. Any diffuse.
No, there is no audio.
Hello.
There is no audio.
Hello.
Yeah, talk.
Hello. Yes, sir. Hello,
Yeah, please talk loudly.
sir. In cases of
డేవిడ్ అందరి వాయిస్ తక్కువ వస్తుంది డేవిడ్ నీది కూడాను.
అందరి వాయిస్ తక్కువ వస్తుందా?
సార్ సార్ వాయిస్ బాగానే ఉంది కదా సార్.
బషీర్ని అడగాలనుకుంటా.
డేవిడ్ సార్ వాయిస్ క్లియర్ గానే ఉంది సార్. ఆ అమ్మాయి మైక్ దూరం పెట్టేస్తుంది.
హలో.
మైక్ దగ్గర పెట్టినా కూడా వాయిస్ తక్కువ వస్తుంది. దేర్ ఈస్ సమ్ ప్రాబ్లం. ఇందాక మీరు వాల్యూమ్ తగ్గించారు కదా, ఎవరో ఒక అతను వచ్చి ఇంక్రీజ్ దట్ వాల్యూమ్.
ఇంక్రీజ్
బాగా కింద ఏదో వాల్యూమ్ ఉంది కదా, అది కంప్లీట్ ఫుల్ పెట్టేసే 100.
అది స్లైడ్ జూమ్ అనుకుంటాను సార్.
జూమ్ కాదు, అది జూమా వాల్యూమ్ కదా.
జూమ్ అవుతుంది సార్, జూమ్ అవుతుంది, వాల్యూమ్ కాదు.
అది కాదు
ఇందాక
ఇందాక అతను
ఇందాక పెట్టింది స్పీకర్ వాల్యూమ్ సార్.
అది పెంచాలి. ఎవరు ఎంత శ్రీనివాస్ అనుకుంటా. శ్రీనివాస్ ఇంక్రీజ్ ద వాల్యూమ్ ఫుల్ 100%.
అది కాదు, అది మాకొచ్చే వాల్యూమ్, మీకొచ్చే వాల్యూమ్ కాదు.
మాకు వచ్చే వాల్యూమ్ పెంచండి, మీకు వచ్చేది ఎందుకు?
నాకు అదే అంటున్నాను, అది అది పెంచితే మాకు వచ్చే వాల్యూమ్ పెరుగుతుంది సార్, మీకు వచ్చే వాల్యూమ్
అదే
పెరగదు.
నీ వాయిస్ కూడా చాలా లో ఉంది. దేర్ ఇస్ సమ్ ప్రాబ్లమ్ ఇన్ ద ఆడియో.
అది మైక్ ఇష్యూ. ఏ మైక్
మైక్ ఇష్యూ ఆర్ సంథింగ్. నెక్స్ట్ టైం వాట్ యు డూ, డోంట్ టాక్ ఇన్ ద మైక్ అండ్ ఇంకా డైరెక్ట్ గా ఇది ఇయర్ ఫోన్స్ పెట్టుకొని మాట్లాడము.
అదే బెటర్ సార్. ఓకే.
We are not able to understand the voice particularly. You are telling loudly, but we are not able to hear.
సరే.
Very low volume. So okay, next time you clear that is audio problem. Sindhu.
Yes, sir. Can you hear me, sir?
Yeah, no, still it is low, but anyway, thank you for the nice class. We will close with the anatomy, and please next time you continue on pathology. Okay. Hello. ఎవరు రెస్పాండ్ అవ్వట్లేదు.
డేవిడ్ గారు,
అందరి పెద్దగా వినిపిస్తున్నాయి సార్, అక్కడ మాత్రం కేరళలో అసలు ఏం వినిపించట్లేదు.
ఇంట్రెస్టింగ్ టాపిక్. మీ వాయిస్ వినిపిస్తే చాలు కదా సార్.
వెంటలాగా స్పీకర్ వాయిస్ లేకపోతే ఏమంటాం సార్. అది వాళ్ళు 50 చేశారు కదా, యూ మేక్ ఇట్ 100.
ఓకే ఓకే.
ఇది ఎవరిది చేసింది? హలో సింజు. ఎనీవే,
డేవిడ్,
ఏంటి మేడం ప్రాబ్లం ఏంటి అక్కడ ఆడియో?
అది తెలీదు, ఓపెన్ అయింది, స్లైడ్స్ వస్తున్నాయి కానీ మీకు వాల్యూమ్ వినపడట్లా ఇక్కడ గట్టిగా మాట్లాడినా.
సరే, అది క్లియర్ చేయమనండి. నెక్స్ట్ టైము అది దీనికి ల్యాప్టాప్ కి డైరెక్ట్ గా ఇయర్ ఫోన్స్ పెట్టుకుని మాట్లాడమండి. దెన్ ఇట్ విల్ బి గుడ్.
అలాగే మీరు ఒక క్వశ్చన్ అడిగారు కదా, వేర్ సిటీ ఇస్ ప్రిఫరబుల్ దాన్ ఎంఆర్ఐ అని. దానికి ఆన్సర్ చెప్తాను,
చెప్పమానండి.
Sir, Rajesh Madratni. So,
okay.
Indications of CT over MRI. First indication is trauma, sir. Any conditions of trauma, head injury. So, CT is the first preferred modality. Now, in cases of acute stroke, in days of acute stroke interventions, like when you want to go for an IV thrombolysis, presently plain CT is sufficient to rule out any intracranial bleed and to start IV thrombolysis. One of the other indication. And any condition where the patient is unstable, where the patient is not a candidate to do MRI, claustrophobic, or need to give anesthesia for longer duration, and patient is not clinically stable on inotropes or any other medications. So those are all indications where we can do a CT over the MRI, sir.
Okay, sir. Thank you. Any questions from audience?